Blood pressure is the focus of this brief section. I was hoping that we could get through all this material in one class. It's not probably going to happen. It might spill over to next week, but blood pressure is our focus. We're moving out of the heart into the vasculature. So, this section will focus primarily on what factors influence blood pressure, what factors cause there to be pressure in the blood. Why is the blood pressurized? We're going to look at how blood pressure changes, specifically how it's influenced by cardiac output, which we already know. And then two things that we don't know yet, mean arterial pressure and vascular resistance. We're going to explore the relationship between those three factors and how they ensure delivery of blood to the body, perfusion of the organs in the body. And lastly, we'll look at some mechanisms for controlling blood pressure. There are nervous inputs, a lot of which we've seen already in discussing cardiac output. And there are hormonal inputs that have to do with the regulation of blood volume at the kidneys. And we won't go into depth because we have a section on the kidneys coming up, but I'll introduce those factors that we'll connect back to later in the course. The theme of this section is written here. Without pressure, there is no flow. And this is an important concept to keep in mind. The reason that there is blood pressure is to ensure blood flow. From the body's point of view, from a systemic point of view, if the arteries weren't pressurized, blood would not travel through the arteries. Without pressure, there is no flow. You can imagine attaching a hose to the end of this hydrant. Clearly, this water is pressurized somehow, some way. If you attach a hose to the end of this hydrant, you can direct water out of the end of the hose. There's flow through the hose. If this weren't pressurized, due to gravity from a water tower nearby, if you put a hose on the end of the hydrant, water would simply just sit there. If there weren't pressure pushing water through the hose, it wouldn't travel on its own. Pressure needs to be there in order for there to be flow. Excuse me. So blood flow. We've thought about blood flow in general overall terms, but we can break it down a little bit more. If we're considering pressure and flow in terms of the body now, whereas on Tuesday we did it in the terms of the heart, if we're thinking about it from the point of view of the body, blood flow could be to any organ. Leg blood flow, liver blood flow, brain blood flow. And each of those is likely to be different. Not all tissues need the same amount of blood. Some need more, some need less. That need changes. But blood flow, with respect to an organ, is the amount that travels to that tissue in any given time. Still mils per minute, same units as we discussed on Tuesday, but here specific to an organ. Now, as we know it, it's total blood flow. We've talked about cardiac output or flow in the systemic sense. The total amount of blood being supplied, the total flow rate being supplied. We know that to be heart rate times stroke volume, and sitting here at rest, it's about 5 liters per minute, or 5,000 mils per minute. All of the individual tissues in the body will take a portion of that blood flow. A liter per minute might be sent to the brain. Some might be sent to the intestines. Some might be sent to the liver. That total blood flow, cardiac output, Q or CO, is the total blood that travels through the systemic and pulmonary circulations. So from the point of view of the heart, flow was heart rate times stroke volume, the amount that we are pushing out into the body. From the body's point of view, and depending on where you are in the body, that can change. Flow is a function of pressure and resistance. Pressure in the arteries and the resistance to flow through the arteries. And we'll talk about each of those terms. See if I can cut down on some of that background noise. So the velocity, or the flow of blood through the vessels, depends on pressure in the vessels and resistance in the vessels. So let's talk quickly about pressure. We'll rearrange this equation. It'll hopefully make some sense. Let's talk about pressure quickly. One way to help bridge the gap from the heart's point of view to the body's point of view is to think of the heart as generating pressure. Every time it beats and it pushes blood into the arteries, more stuff in a confined space means more pressure is generated. Contraction of the ventricles generates blood pressure. That pressure dissipates as blood travels to the rest of the system. But every time the heart beats, forces more blood into a confined space, the pressure in that space increases. And pressure is the regulated variable. Pressure is the thing that we're trying to maintain. Without pressure, there's no flow. We need to maintain pressure to make sure all the tissues in the body get blood. And pressure is dictated by how much blood the heart is trying to force into that space. It's dictated by how much blood there is and the size of that space. And when I say that space, I'm really simplifying all of the arterial systemic circulation down to one point. I'm assuming it's one space, but it's the entire circulation. It's determined by the amount of blood being injected, the amount of blood, and the resistance, or the size of that space. So, one way that we can reframe this equation to make it a bit more intuitive. Well, first let's explore this equation. Without pressure, there is no flow. Flow will increase if pressure increases. I think that makes sense. Flow will decrease if resistance goes up. That's what this equation is saying. We don't know what resistance is yet. We'll get into that in a coming slide. But a way to reframe this with pressure as the focus would just be to rewrite the equation as follows. Multiply both sides of the equation by resistance, the resistance factor. And I'm using TPR in this equation. It stands for total peripheral resistance. That's coming up on an upcoming slide. I just want you to know that now. It's the resistance to flow. So pressure, that seems to be getting worse. Not flickering. Mean arterial pressure is a function of flow and resistance. Now, we haven't seen resistance before, and let's assume it doesn't change very much. If pressure goes up, flow goes up. The higher the blood pressure, the greater the blood flow. The lower the blood pressure, the lower the blood flow. At some point, if there's no pressure at all, blood will sit there and pool and not move. If resistance doesn't change, if one item on the left side, flow, goes up, pressure goes up, and vice versa. So, we see a trace of blood pressure throughout the systemic circulation over on the right-hand side. You can see that the heart is infusing pressure with every beat. Every time the ventricles contract, pressure spikes. In between beats, we have the rebound effect that carries blood away. Blood flows away from the heart, and pressure drops back down. And we have this pulsatile relationship throughout the arterial systemic circulation. We can observe that pulsing in almost any artery. Pressure drops as we approach the muscular arteries, the small arteries, through the capillaries, and then into the venous circulation until it reaches almost zero back at the heart. And this is really important. It's because of this relationship that blood flows in a circuit. Blood moves from high pressure to low pressure. It moves from arteries to veins. It cascades, it runs downhill until it reaches the heart at the end of the circuit. Now the heart's not shown here. It approaches near zero in the right atrium and the right ventricle. And presumably this little blip is due to contraction of the atria. It generates a little bit of pressure to fill the ventricles up. And there's a little blip at the end with every beat of the heart. But for all intents and purposes, this is a linear decrease. As you move through the systemic circulation, pressure drops until it approaches zero back at the heart. And that ensures flow from the left heart through the body back to the right heart. So pressure is a pretty important variable. Let's look at how we would calculate pressure. And you don't have this slide in the slide set on Moodle. I just added this because I thought it would help clarify some things a little bit. How would we calculate pressure? At rest, the equation to calculate mean arterial pressure is shown here. On the last slide, we saw this undulating, pulsatile pressure in the arteries. It was high, then it was low, then it was high again. But there is an average pressure. And you would calculate the average pressure according to this equation. 1/3 systolic pressure plus 2/3 diastolic pressure. Why 1/3 and 2/3? Let's revisit our old friend. This is the pressure trace of the Wiggers diagram showing the cardiac cycle. We have the entire cardiac cycle shown here. And I've moved the window a little bit, but all of the elements in the cardiac cycle are under the umbrella of this green term. The systolic pressure appears, here we go, for 1/3 of the cardiac cycle, and the diastolic pressure is evident for 2/3. That's how we get this calculation. 1/3 SBP, systolic blood pressure, plus 2/3 diastolic blood pressure. So the spike lasts 1/3 of each beat, and then the trough, roughly 2/3 of each beat. The mean pressure, therefore, has to be scaled appropriately. So if we were to do a sample calculation using numbers that we know really well, 120/80, normal blood pressure. Systolic pressure is 120 millimeters of mercury. Diastolic pressure is 80 millimeters of mercury. I simply plug those numbers into this equation. If you're following along with a calculator, you'll know that 1/3 of 20 is 40. 2/3 of 80 is 53.333333. And so mean blood pressure, or mean arterial pressure, is 93 millimeters of mercury in this case. Now, of course, that value will change if systolic pressure changes or if diastolic pressure changes. This is an example. Is this the same calculation that you would use, or the same equation you would use during exercise, do you think? See some head shakes, that's good. It's not. It's not, because the cardiac cycle shortens. Heart rate speeds up. And this resting period gets smaller. So if you were to calculate mean arterial pressure during exercise, the general rule, cardiac cycle shortens, systolic pressure would take up half of the cardiac cycle, and diastolic pressure would be evident for the other half. So it's an easier calculation during exercise. You're probably right to think that it'll change depending on how quick the heart rate is or how compressed the cardiac cycle gets. But in general, we use the equation 1/2 systolic plus 1/2 diastolic to calculate mean arterial pressure during exercise. So, pressure, usually always in this range. If anything, it goes up during exercise, never really goes down, certainly never drops towards zero. If blood pressure drops, you faint to make sure that your brain can get enough blood, remove the effect of gravity. Blood pressure is always maintained. So blood pressure ensures that there is flow. But we're missing one important piece of the puzzle. How does resistance come into play? And what is resistance, for that matter? Resistance is a term to describe vascular resistance or systemic resistance. I think of it as total peripheral resistance. If you took all of the arteries, all of the vasculature in the body, and you combined them together, and you thought about how hard it would be to push blood through that new combined vascular system, I'm describing total peripheral resistance. Once blood leaves the heart, it doesn't have an easy job. It doesn't just spill into the arteries. There's opposition to that flow. And the opposition is specifically due to friction between the blood and the walls of the vessels as it's pumped through. Walls are stationary, blood is moving. There is disagreement between them. The blood wants to make the walls move, but the walls are a physical, stationary object. The walls want to slow the blood down, and that slowing is resistance. Friction between the blood and the vessel walls. It's also called shear stress. The shear of blood as it passes over the flat surface of the vessel walls. Now you might think then that there is only one resistance. but we can modify resistance if we need to. We can change the influence of that friction to oppose blood flow. There are three main factors that affect resistance. By far, the most important is the size of the lumen, the size of the tunnel, the diameter of the vessel. How constricted it is, or how dilated it is. The more open, the more dilated, the less resistance there is to flow. The more constricted, the more resistance there is to flow. And you can follow that through. Theoretically, if you close the vessel off completely, that resistance would be infinite. There would be no flow. If it's closed completely, way too high, the resistance won't allow flow to go through. It never gets to that point, but you can imagine what that would be like. So smaller, more constricted vessel means more resistance. More open, more dilated vessel means less resistance. So, resistance. Resistance is very sensitive to changes in the size of the arteries. And which arteries are those that can change size? Muscular arteries, small muscular arteries, or the arterioles. Small muscular arteries or the arterioles. That's their job, to constrict or dilate, to change resistance, to affect pressure, and alter blood flow. That's the point of the arterioles. So in a normal, healthy individual like you, or hopefully I, that is the factor that will dictate resistance. There are other factors that will affect resistance though. Blood viscosity will affect resistance. If your blood is more viscous, there is more resistance. That happens in situations where you are dehydrated. It happens in situations of blood doping where you have too many red blood cells, or other diseases where it affects protein or red blood cell content in the blood. It essentially means there's more stuff that hits the walls as blood is flowing through the vessels. There's more stuff. If it's more viscous, there's more friction and more resistance. It doesn't change very quickly. You or I sitting here would not experience a change in blood viscosity easily. It would take a fair amount of stress, a couple hours, to do anything to affect blood viscosity. Similarly, we'll never see a quick change in the amount of vasculature that we have available, the length of the vessels in the body. We have a certain relatively fixed length of arteries, length of capillaries, length of veins. Those can change with some training. We make new arteries. Some overweight or obese individuals with more adipose tissue, with more fat mass, make more arteries to supply that fat mass. So the total length of the vasculature can change. And the more blood, the more conduits, the longer the length, the more the resistance. It's one of the primary reasons why overweight individuals have hypertension, have high blood pressure. The resistance to flow is large. So overall, constriction, dilation of the vessels in healthy individuals, that is the factor that controls total peripheral resistance. So, without pressure, there is no flow. Pressure is the regulated variable. We always maintain pressure within certain limits. By altering how much blood the heart tries to push into the systemic circulation, and by altering how much resistance there is to that blood being injected into the systemic circulation. Both of those factors regulate pressure. We want to maintain normal pressure. It's worth noting at this point that we kind of take for granted that the heart has blood to pump. Ventricles fill, stroke volume exists, the heart beats at a certain rate, cardiac output ensues. Cardiac output attempts to maintain pressure in the vasculature, but how do we make sure that the heart sees enough blood returning to supply cardiac output, to supply blood to the arteries? What I'm describing is the phenomenon of venous return. And at the risk of complicating things, the only reason that we have return of blood through the venous circulation to the heart is because of this pressure gradient, because we've maintained normal blood pressure and blood flows downhill, quote unquote. And I say quote unquote downhill because blood flowing to my feet and then back to the heart isn't flowing downhill, it's flowing down the pressure gradient, but it's vertically returning back up to the heart. So blood always flows from high to low pressure. That blip there is the atrial contraction. And we know a few of the mechanisms that help support venous return. Adequate pressure is one to maintain this cascade and return blood to the heart. But there are other accessory factors that help return blood to the heart. You've seen in lab the valves on the venous side, the one-way valves that ratchet blood back up on the venous side to the heart, that prevent backflow of blood and pooling in the feet. So the valves are the first and foremost, the easiest to observe. And we have two other mechanisms. There's a pump from muscle contraction. The muscles push blood back up towards the heart, and the lungs pull blood back towards the heart. There are skeletal muscle and respiratory pumps. So all of these things help to ensure blood returns to the heart. And I want you to appreciate how important this is. Pressure on the venous side, it does follow a cascade. It goes from high to low, but the range is really small. There's a difference of 10 millimeters of mercury between the heart and veins in your feet. And it's really easy to disrupt that gradient. When you stand up quickly and you see stars for a little bit, that's you disrupting this gradient. I had a friend in undergrad. We were downstairs watching, I think it was The Office at the time when it was back on Thursdays, not on Netflix. During a commercial break, he stood up real quick off the couch, ran upstairs to get a snack, and I just hear this thud. He blacked out and just knocked his face off the counter, woke up a second later, didn't really know anything had happened, had a little bit of a sore cheek. But because he was able to disrupt this pressure gradient so completely, blood couldn't flow back to the heart and there wasn't an adequate supply to the brain. And so the body's fail-safe in that case is to remove gravity from the equation. If you're horizontal, it's really easy to get blood back to the brain. And so that's what he experienced. If you did that right now, getting up quickly and running up these stairs, something similar might happen. Don't try it, but something similar might happen. So it's really easy to disrupt this very small gradient, and these factors, these accessory structures, help maintain venous return. So, valves, you know. I'm not going in depth on the one-way valves, although we do see them here, and they do come into play with the skeletal muscle pump, which is best exemplified in the legs. Running, cycling, walking upstairs, doing brief clenches with your toes, all help to push blood back up to the heart. So normally, on the far left-hand side, there's no contraction, the veins are open, and blood is flowing back to the heart according to the pressure gradient. There's a higher pressure at the feet and a lower pressure at the upper leg, so there is some blood flow up towards the heart. And the one-way valves here will help make sure that blood continues to flow up and doesn't flow back down towards the feet in the pool. So blood follows the pressure gradient if we're standing normally. Now if you stand up on your toes and you do this repeatedly, or if you start to run and you're engaging the calf muscles, the soleus and the gastrocnemius, you can see there's a mechanical force of contraction. The stress or the pushing of the muscles on the veins pushes blood outwards. The muscle deforms the vein. And so as the vein is compressed, it's like squeezing a tube of toothpaste. You squeeze it in the middle like a monster. Some will come out the top and the rest will go at the bottom. Luckily, the bottom of the toothpaste tube is closed, and that's analogous to the one-way vein here. It catches the blood and stops it from pooling back down on the feet. That pushing on the venous walls pushes blood up. Then when the muscles relax, blood fills the space in here again as blood follows the pressure gradient. The one-way valve at the top near the knee prevents backflow of the blood back down to the lower limb, and that repeats over and over again. Pumping of the blood back up to the heart, a lot like you would fill the blood pressure cuff using that bulb to gradually increase pressure. It's a lot like the muscles pushing blood up through the venous circulation back to the heart. So the valves help to catch the blood. The muscle pump pushes the blood up from the lower limbs. The respiratory pump helps pull blood through the right side of the heart. This is also, unfortunately, not in the slide set online, but I thought this would help to illustrate that purpose a little bit. This is simply a diagram showing the respiratory or pulmonary circulation. And this is not anything new. You see the right side of the heart, the right atrium and ventricle, through the pulmonary trunk and pulmonary arteries, supplying the lungs, and then returning through the pulmonary veins to the left side of the heart. You know this pulmonary circulation well. Every time you breathe in, which we haven't articulated yet in class, but I think that you've seen briefly in lab, and even so far back as last year when you talked about the diaphragm contracting to help breathing. When you breathe, with every breath, you create a negative pressure, negative thoracic pressure, or a decreased thoracic pressure. And that's good. For the lungs, it helps to move air in. There's air out here. By decreasing pressure in the thorax, I create a gradient, and that pulls air through my nose, through my mouth, through the primary bronchi, bronchioles, to the alveoli, gets air into my lungs for gas exchange. All because of that pressure gradient. Well, a secondary effect of that pressure gradient, it doesn't only create a gradient for air, low air in the lungs, or low air pressure in the lungs versus higher air pressure outside. It creates a pressure gradient for blood as well. It depressurizes the blood in the pulmonary capillaries, in the pulmonary arteries. It makes that gradient steeper, which helps to move blood from the right heart into the lungs, which opens up space in the right heart and helps to pull blood from the circulation back to the heart. Emphasizing here this movement of blood to the lungs in this case. Does that make sense? I don't see any confused faces, which is good. I don't see excited faces either, but that's okay. So respiratory pump, muscle pump, valves, and the pressure gradient overall. So if pressure decreases gradually over time and ensures flow back to the heart, now we're left with, well, we've already introduced the flow of blood through the systemic circulation and cross-sectional area. This might maybe start to make a bit more sense now. If we think about flow through the entire vasculature, where we have high pressures, we also have very quick flow, a high velocity of flow. And as pressure drops, velocity tends to drop. Now, it doesn't drop in lockstep with the changes in pressure. Velocity and pressure are related, but the other factor that impacts the velocity of blood flow is shown here in green, the cross-sectional area. We have a very large vascular bed in the capillaries, lots of space for blood to circulate and pool, little pressure, which makes for little flow in the capillaries. So really at this point, this is all review. This was even a question on one of the quizzes that we did in class. Blood flow is inversely proportional to the cross-sectional area. And we'll just leave it at that. Before we go, I want to introduce this concept. We'll pick this back up next week, because I can't get through regulation of blood pressure in the last 5 minutes, but I want to introduce this concept, unveil it a little bit. It's not so scary because a lot of the things on this slide we've talked about already. When trying to understand the regulation of blood pressure from the body's point of view, and if you're bombarded by all the factors on this slide at first, it seems overwhelming until you realize and break it down that a lot of the factors that affect blood pressure are the same factors that affect cardiac output. And those are already up here on the slide. So, parasympathetic inactivation, sympathetic activation, an increase in stroke volume, an increase in heart rate. All of those things we know will increase cardiac output. And from the point of view of the heart, that's where we left off. But now, as we focus on the body as a whole and the other tissues in the body, cardiac output is only one factor influencing mean arterial pressure, flow through the rest of the body. What we've added today is a bit more of an explanation for how and why venous return is maintained. We've looked at the respiratory pump, the skeletal muscle pump. We didn't talk so much about an increase in blood volume, but if there's more blood, it's easier to move blood back to the heart. Or if you constrict the veins, you push blood back to the heart. That's analogous to the muscle pump itself. And this is one factor affecting mean arterial pressure. The antagonist, like we introduced, is resistance. Resistance wants to oppose flow. An increase in resistance will increase pressure. And I mentioned that for all of us, healthy individuals, by far the biggest factor affecting resistance is the radius of the vessel, the radius of those small muscular arteries. Even where the other factors are slightly different, on a moment-by-moment basis, the radius is what regulates total peripheral resistance to help regulate blood flow. We can't acutely change viscosity, we can't acutely change blood vessel length, but we can certainly open and constrict vessels quickly. So I'll leave that here. We'll look at the integration at the cardiovascular center when we get back to class next week. Midterm tomorrow. Remember, 12:30 the survey opens if you want to go to the cadaver lab. Otherwise, have a fantastic Thursday night. Study hard and good luck.